This was a very interesting session that basically revolves around topics that we've been having since many years and which are not yet fully resolved, I would say. So the session started off by Franz Ruschkitzker from the University of Zurich, who mentioned how important and advanced CRT was and that we can really be proud of what we're doing for our patients and also by the important improvement in the patient's symptoms and outcome thanks to this therapy. And then we had a session on echo optimization that was given by Ole Breithardt from Germany. Now, Ole was explaining to us how important echo optimization may be, at least in his hands, because he is also an echocardiographist. And so for him, he does this routinely in all patients and finds it's very important. This viewpoint was not quite echoed by Mads Kronborg from Denmark, who believes that echo optimization is sometimes quite tedious and long, and he overviewed also other methods of optimization such as the automatic algorithms. And we also had Michael Glickson, who talked a little bit about the CRT indications and also briefly mentioned that conduction system pacing was not a substitute for biventricular pacing. So my own take on this is that I do believe that CRT optimization is important because it can make a difference in, I would say, a minority of the patients. It's very difficult to prove this by randomized studies because there are so many different factors that come into patient response. Patient selection, lead position, which was also covered by Michael Glickson, and also the optimization. So it's really diluted. But I'm convinced that in selected patients this can really make a difference. I think what was not very much covered in the session was the importance of the ECG, which is important not only for patient selection, but can also be a very easy, cheap, quick, and effective tool for optimization. So I use the algorithms which are in the device, the AV/VV optimization, the automatic algorithms, but I always check with ECG. And I always look out that the pacing spike, the ventricular pacing spike, is at least 40 milliseconds after the end of the P wave. So that leaves enough time for the left atrium to contract and to avoid A wave truncation, which we can see by echo. The other thing I really look into is the QRS. What you want to see really is QRS narrowing. That's really important. And the QRS that looks as physiological as possible. And in some instances, you may, if you don't have those two factors, then have to optimize by echo, but that's maybe only in 10% of the patients. So by doing so, I think we really can offer the maximum benefit for our patients with CRT. So that's it from me. Thank you very much.